Hello, everyone, and welcome back to class. Hope you are doing well. So, we're talking about diagnosis right now. And when I came up with the topics for this particular class, I wasn't sure if anybody was going to be interested in doing anything with diagnosis. It appears that most of you are doing stuff with therapeutic trials or looking at therapeutic interventions, and that's great. But I wanted to include this information in case you need to include any diagnostic information in your dissertation. Obviously, we are utilizing tests within our practices in order to better understand what's going on with the patients. But sometimes we don't need to do a test to know what happened. If we've got video here in honor of March Madness, here's a oldie but goodie. And you see that there on the left knee. Do I need a special test for the knee to be able to identify what happened there? Probably not. Probably we just need to get that individual to the ER, evaluated in the ER, and then prepped for surgery whenever the orthopedist has the time to do an ACL surgery. In that particular case, the individual had an ACL tear, an MCL tear, a meniscus injury. So diagnosis, here are the things we are talking about. And let's look at these on the next slide. Diagnosis is all about probabilities and limiting uncertainty. So do I possess a test that does a good job of identifying an ACL sprain? Do I have a test that does a good job of identifying a meniscal injury? Now, for any given patient, there is a baseline probability of a certain condition pre-testing. So based upon my patient history and the types of patients that I usually see, there is that baseline probability. We're going to be interested in knowing, can the test we use shift that probability, either increase it or decrease it? So again, by performing those diagnostic tests, it helps us to rule in or rule out of the diagnosis. How do we know which test or tests to use or not to use? Well, one way is through evaluating the research literature. Here are components of a diagnostic study. We'll look at these on the subsequent slides. Do these look familiar to things that you've discussed in class? Hopefully they do. Let's take the example of an ACL tear and doing a Lachman's test. If we're evaluating a study looking at the Lachman's test for an ACL tear, we want to compare the results from the Lachman test with a gold standard. And we want to have a blind comparison. So one individual is going to do the Lachman's test, and another individual blinded to the results would perform the MRI, the gold standard test. The diagnostic test evaluated should be done to an appropriate spectrum of patients. Now, it wouldn't be done to everybody that comes through the orthopedic office door. Wouldn't need to be done to somebody with a low back pain case or a shoulder injury, but probably should be applied to everybody with knee pathology. Why? Well, if you apply it to everybody with knee pathology, you're making sure that you're reducing false positives and false negatives. The gold standard should be applied to all individuals regardless of the diagnostic test. So all the individuals enrolled in the study that had the Lachman test performed, whether or not they were in for an ACL injury or a patellofemoral pain syndrome case or maybe knee OA, they should all have the gold standard test done. And the diagnostic test should be validated in a second independent group of patients. Now, sometimes you'll see this in a study, and other times, more than likely, it'll be in a follow-up study. So online, there's Ebinger et al., and I want you to answer these questions. Read the article and answer these questions. Obviously, you don't need to discuss with your nearby peers because you're doing things all online. This is when I do this class in person. So I'll give you an opportunity here in a moment to pause the recording. If you just want to follow along, please do so. It won't take you long to read the article, though. So let me give you 5 seconds of dead air now to go ahead and pause the recording. And I'll continue on now. I'm going to assume you've either read the article or you're just going to follow along and continue on with us. So in this study, they were looking at a SLAP lesion or a SLAP tear. SLAP standing for the superior labrum, anterior to posterior, and it is a lesion or a tear to the glenoid labrum. And this injury occurs at the origin of the long head of the biceps. Potential causes include throwing motions or overhead sport activities, weightlifting, blocking a fall with an outstretched arm, or part of the degeneration process of life, aging. Now, I think the authors talk about the need for this particular study by saying that the sensitivity and specificity is disappointingly low when it comes to looking at special tests for the labrum. Now, there are gold standard tests, the MRI, which is costly, and then arthroscopy, which can obviously increase risk. So a couple tests cited in the paper were the active compression test, also known as the O'Brien test, and the SPEEDS test. The active compression test, in the original study by O'Brien, had incredible sensitivity and specificity, was listed at 100% sensitivity and 98.5% specificity. But subsequent studies illustrated potential flaws in that initial paper, and so the sensitivity is closer to 67% and specificity 37%. The SPEEDS test, sensitivity 20%, specificity 78%. So Ebinger again cited the need for this study that current special tests have poor diagnostic utility. And the need for special tests are there because they may help to reduce medical costs or the need to do invasive procedures. So they came up with the supine flexion resistance test. Laying supine, arm is positioned overhead, which may be uncomfortable for some people with acute shoulder injuries in general. The clinician grasps the patient's arm just distal to the elbow. Patient's asked to perform a forward flexion of the arm. Test is positive if it elicits pain deep inside the shoulder joint or at the dorsal aspect of the shoulder. Type 2, the most common type of SLAP tears. This is one that the authors suggest. This test is good at identifying. There are some additional types of SLAPs. Question 1, was there an independent blind comparison with a reference standard of diagnosis? And the answer is yes. 2 surgeons performed the arthroscopic procedure. The physical examination was performed by a different person. Was the diagnostic test evaluated in an appropriate spectrum of patients? Maybe. There were 150 consecutive patients presenting for arthroscopic surgery of the shoulder for a wide variety of complaints. The reason I say maybe is some might argue that that's okay. But I would also argue that probably the test should be done on every shoulder patient that comes through the clinic door, not just those who are waiting for arthroscopic surgery. Was the reference standard applied to all? Yes, it was. Was the diagnostic test validated in a second independent group of patients? And the answer is no. And at the time that I prepared this presentation, it does not appear that this test has been validated in a second study. So what were their results? 80% sensitivity, 69% specificity, 36% positive predictive value, and a 94% negative predictive value. So how did they match up versus the Speeds and the O'Brien test in this study? Well, the authors concluded that the supine flexion resistance test had better specificity than the other two tests, which it did, but is 0.69 great? Not great. It was better than the Speeds test, but not better than the O'Brien's test. Is 0.8 good? Well, they concluded that the test was effective for detecting type 2 SLAP lesions. But you're going to find that in these types of studies where the authors are going to really advocate for the value of their test because it brings them recognition, brings them some fame or notoriety. So again, how do you learn about diagnostic utility of the various tests? Well, it's part of your PA education. You're going to learn about it by searching the literature, going to PubMed, something like that, putting in the name of the test you want to look at, and looking at sensitivity or specificity or diagnostic accuracy. For example, putting in here slump test, a test for sciatica, and sensitivity came up with 25 citations. Or you can add different reference texts to your professional library. And if you have an interest in orthopedics, I would recommend this Cook and Hedges book. Now, Cook and Hedges are both physical therapists, but it is not a book on how to do a physical therapy exam. This is an encyclopedia where it will present a test, what its purpose is, how to do the test, and then it presents study by study. It doesn't list the studies and describe them, but what they do is they present a table and they present the sensitivity and specificity, the positive and negative predictive value, and the likelihood ratios for each of the different studies. So it gives you kind of a comprehensive view of the range of scores that are out there for a particular test. Now, it's great when a test does a good job. An example of one of those is the Lachman test. And we'll explore that here in a little bit. Unfortunately, there are tests that don't do a great job, and one of those is the McMurray's test for the meniscus. What I want you to understand and appreciate, though, is the sensitivity and specificity. Understand what a patient may be interested in when it comes to positive and negative predictive values, and know how to apply likelihood ratios. So let's look at the stats. Here's the 2x2 table. You've probably seen this before for assessing diagnostic text accuracy. We've got one column for sensitivity, one for specificity and how to calculate it, and rows for positive and negative predictive values. Sensitivity is our true positive rate. This is the proportion of people with the disease who will have a positive result. A highly sensitive test correctly identifies patients with the disease. A test that is 100% sensitive will identify all patients with the disease. A test that is 90% sensitive will identify 90% of the patients who have the disease, but will miss 10% of those patients. A test with high sensitivity can potentially help to rule out a disease. So, for example, snout. You may have heard that before. High sensitivity, when the test is negative, helps to rule it out. What is high sensitivity, though? Is 70%, is 80% high sensitivity? It's obviously higher than 20 and 30%. There isn't like an agreed upon number within the physical therapy world that says this number has to be it. I think people will feel comfortable about sensitivities and specificities above 90% when using the snout and the spin, but it's not a hard and fast rule. What do you know about things within the PA and medicine world? And maybe it's different depending upon the type of test you're using. So a test with high sensitivity has high true positives and low false negatives. Test with low sensitivity has low true positives and high false negatives. Now, specificity, or the true negative rate, that's the proportion of people without the disease who will have a negative result. Specificity refers to how well a test identifies patients who do not have a disease. A test has 100% specificity will identify 100% of the patients who do not have the disease. Something with 90% specificity will identify 90% of the patients who do not have that disease. Tests with high specificity are useful when the result is positive. So SPIN, highly specific test, when the test is positive, can be useful for ruling in patients with a certain disease. High true negatives, low false positives, that's associated with a test that has high specificity. Vice versa, tests with low specificity have low true negatives and high false positives. What about false positives and false negatives? These probably have more concern for the things that you do. For example, a false positive, when a patient gets a positive test, but they actually should have got a negative test. So this is a false alarm or a false positive error. For example, positive pregnancy test, but the individual is not pregnant. Or the cancer screen comes back positive, but one does not have the disease. Or a prenatal test comes back positive for Down syndrome, but the child is not born with it. Obviously, false positives can be worrisome. How would you feel, or how is your patient going to feel if a test identifies them as having a serious disease? One example is the PSA test. Up to 25% of men with high PSAs have prostate cancer, but most of these cancers do not cause problems. They're slow to grow and unlikely to spread. PSA is an inexpensive test, but if the test is abnormal, fees stack up. There are additional tests and consults, including biopsy. Most men with high PSAs don't have prostate cancer. A high PSA may be due to things like an enlarged gland, prostate infection, recent sexual activity, and or a recent long bike ride. Routine PSA tests in 1,000 men from 55 to 69 found that only one death is prevented by using the test. And so there can be complications from treatment, including urinary and sexual side effects. There is also, though, the possibility of a false negative, meaning that one does have the cancer. Let's talk about false negatives. Test result indicates that the condition does not exist, but in fact it does. So, for example, a pregnancy test that says a woman is not pregnant, but she actually is. Or a test reports that one does not have a DVT, but they actually do have one. Is one worse? Is a false positive worse or a false negative worse? And the answer is it depends. For example, under the false positive category, a test indicates an immediate need for something invasive, but it's a false positive. That would be bad. How about a test that indicates a musculoskeletal injury that's non-surgical in nature? The test doesn't correctly diagnose the condition. Well, that's bad, but not as bad, right? There isn't that immediate surgical need. There isn't the need for anything else that may be problematic for the patient, put them at greater risk, use of medications, things like that. Now, false negatives. Let's say a test says you're negative for something, but you actually have the condition and it will get worse without treatment. Well, that is obviously bad. A test says you are negative, but the condition slowly develops and or may not require an invasive treatment. That's bad, but again, is not as bad. Here's something the patient may be more interested in, and that is the positive and negative predictive value. Understanding how much more likely, that's not the right way of saying it, letting them know what the chance is that they might have something. So it's the probability that a positive result means there's a real effect. Positive predictive value, do you have the disease based upon having a positive test? For example, a test for cancer that has a positive predictive value of 20%. That means if it comes back positive, you have a 20% chance of having that cancer. Positive predictive value can be confused with sensitivity. They seem like they might be the same thing, but the positive predictive value is of interest to the patient. It is the odds of having something, right? So if the sensitivity of a test is 80%, well, that's useful for you. You might want to use that test because of those people that have it, it correctly identifies 80% of the people who have it as having it. So you might like that test as one of the tests that you would use. But the positive predictive value is interesting for the patient because that may be different, where maybe the positive predictive value means that there's only a 20% chance that they have the disease in actuality. Negative predictive value, that's the probability that people who get a negative test result truly do not have the disease. So it's the probability that a negative test result is accurate. So again, with a positive predictive value, how worried should one be? Whereas if it's a negative test, how reassured should one be? That's kind of a summary of the PPV and the NPV. Do you ever talk about likelihood ratios? This seems like one of those areas where it's more academic in nature, but maybe this will be an area in the future as AI evolves, that maybe if we have an AI assistant, as you're doing your entry on the computer and as you enter in your lab values for a particular set of tests for a patient, maybe the AI can quickly do this. This is, as we'll see here, this is one of those things where I don't think clinicians ever use this. It's more academic in nature, but I just wonder down the road if it could have some value. So these are used to reduce the uncertainty about a patient's likelihood of having a target condition. So somebody comes into us, they have a pretest probability of having something. And that pretest probability is based upon data from the literature, right? A person presents with certain signs and symptoms. Well, they have a 50% pretest probability of having condition X. Or maybe the types of patients you frequently see, the pretest probability is 50%. So it could be based upon clinical experience or it could be based upon research literature. The likelihood ratio then is a tool that can be used to see if a positive or negative test increases the post-test or decreases the post-test probability of having that condition. And the tool that you use is the nomogram. The nomogram is here. Now, off to the right, it shows what types of positive and negative likelihood ratios will either generate large shifts in probability all the way down to rare or small shifts in probability. So, for example, here there is, in this particular scenario, somebody having a 70% pretest probability of having a condition. They had a positive test, and the likelihood ratio associated with a positive test is a 20. Well, drawing a line through there takes them up to 97. So it really changed the post-test probability of that person having that condition. So let's kind of explore some of the academic side of things. Pull up this link. We can do some math. All right, let's assume you've got the link pulled up now. Calculate the sensitivity, specificity, positive and negative likelihood ratios, and the PPV and NPV for these tests. Is this what you got? How about now, let's calculate the sensitivity, specificity, PPV, and NPV, and use 0.27 for prevalence. And let me give you a few seconds here before I jump ahead. You can pause the recording if you're going to do the Math now. All right, now let's take a look at did you get these scores? If so, you did a nice job doing data entry. Okay, so what do the stats mean to you as a clinician? Well, understanding the 2x2 table and formulas allows you to understand the research process and the meaning behind the stats. You may participate in a research process in the future, a research study. That would be interesting. So you'd be able to help out in that process. And understanding the meaning behind the sensitivity, specificity, and other diagnostic utility scores will empower the choices you make as a clinician. So going back to the Lachman test, that was one I said was really good for orthopedic special tests. Rubenstein, who was a doctor, retired recently from the Portland area, published in the American Journal of Sports Medicine, look at the Lachman, a sensitivity of 96% and a specificity of 100%. That's really good. Lee et al. Found some similar data, sensitivity 91% and specificity 100%. Again, Lachman test is great for the ACL. Not all tests are great for things at the knee. The meniscus test, the McMurray's test, is one of those. Sensitivity ranges 16 to 88. Well, you might say, well, gosh, what was that 88 like? Well, I wouldn't focus on the one good. I would see that 18 of 19 had sensitivities less than 70, and 10 of 19 had sensitivities less than 50. Specificity ranges 20 to 100. 12 of 19 did have specificities 90 or more, so can we use that spin? Spin a positive test, would that help to rule in the disease? But then again, with all the other things going on in the knee, if somebody has an acute knee injury, the aggressiveness of the maneuver might also be positive. So this is one of those situations where it's really, really tough to get good scores. So I think what happens a lot of times, and maybe this is your experience, and maybe this is what you've been taught, is we'll do these special tests for people, and it will give us a clinical picture, but maybe not a strong appreciation for what's going on. And then the first step is to start therapy to see if that helps. If therapy helps, great. If it doesn't, maybe imaging is done next. And that's really tough about the meniscal tests is a lot of times with the meniscal injuries, the sensitivity and specificity scores for a lot of them are not great. So what do we do as clinicians when we're stuck with tests with low sensitivities and low specificities? Again, you're doing that subjective examination, finding out what's going on. So many times when the patient tells you what happened, you're able to get a good idea as to what actually occurred. You do the clinical examination, and then you hypothesize or you put as part of your differential diagnosis that the meniscus may be involved. And especially if you can rule out ligament injury, patellofemoral pain syndrome, that starts to get you thinking that that's what's involved. And you look to see, okay, is this something that the person can rehab from and get better? Or if they can't, then do you do imaging and potentially offer a meniscectomy? All right, final section now. This is, again, looking at the pretest probability likelihood ratio based upon your special tests and the use of the nomogram. Again, different tests will have positive and negative likelihood ratios, and that will have large to no shifts in the pretest to post-test value. So here's a case study example, and let's say you're an orthopedic PA, and a lot of patients come into you with subacromial impingement syndrome or shoulder impingement syndrome. And you're going to use these 3 tests to determine if this person has subacromial impingement syndrome. Now, on average, 25% of the patients that present to your clinic have this diagnosis, and so you have a pretest probability of 25%. So this is a 42-year-old male, otherwise healthy, complains of insidious onset shoulder pain. You do the Hawkins-Kennedy impingement sign first. Pain on passive internal rotation is a positive test. there listed from the literature is the positive and the negative likelihood ratios. So using the nomogram, let's say there was a positive test. We would draw a line through the number 2 because number 2 or 2.0 is what the positive likelihood ratio is. So now the post-test probability is increased to 40%. The near sign. Near is full flexion here, positive test, pain with positive overpressure of the upper extremity in the scapular plane. Let's assume there was a negative test when you did this one though. Now our new pretest probability is 40%. We're going to use the negative likelihood ratio of 0.37. 0.37 is a very small shift, so we were at 40. We put it through where approximately 0.37 would be. That drops us down to 18%. Finally, you do the internal rotation resisted strength test. So you're assessing for strength and internal rotation. A positive test was found. Going to our nomogram again. We were at 18%. High likelihood ratio, now we go up to 81%. So now based upon these 3 tests, we see that we have a shift to going from an initial 20% pretest probability to a post-test probability of 81%. So again, it does seem very academic, doesn't it? A lot of times I think people just think about the 3 or 4 tests that they use, and if there was more positive than negatives, they make that assumption. This where I think might be interesting. Will AI do this for us in the future? I don't know. And again, do you ever use it in clinical practice? I don't know. It's not something that we oftentimes use in physical therapy practice. I think people just kind of think about things, and if there's a collection of findings that show a positive result, then we lean towards that as our diagnosis.